This is lecture 19 for microbiology. We're going to be discussing microbial infections or diseases of different tissues. In this lecture, we'll cover microbial diseases of the skin, eyes, and the nervous system. In terms of microbial diseases of the skin, we'll go over some general features. I want to remind you that the skin is the primary defense line or first line of defense. It's part of the innate immune system and gives you a non-specific barrier to the outside world. At your surface on the skin, it is a stratified squamous epithelium, and in areas of your internal surfaces, it is also a stratified squamous epithelium. Most internal surfaces are mucosal epithelia, but in some areas it is stratified squamous. Now, direct entry through the skin, through the stratified squamous epithelium, can occur due to puncturing. This is called the parenteral route of entry. The skin has sweat glands, and they produce perspiration, which is high in salt concentration, so there's a higher salt level on the skin, and salt itself inhibits microbial growth. The other thing that you find in the sweat or perspiration is a protein called lysozyme, which non-specifically can kill bacteria by breaking down through hydrolysis, just like hydrolytic enzymes. Is similar to hydrolytic enzymes. It hydrolyzes peptidoglycan in the bacterial cell wall. The other thing is that in the sweat glands, from the oil glands, which produce sebum, shown here, there is fatty acid in that, and that does inhibit some pathogens. It's a low pH acid material which has inhibitory effects on certain pathogens. In terms of the mucosal epithelium, your inner surfaces between your body tissues and the outside world, there are several different kind of structures depending on where you look, but the characteristic features are the same. Epithelial membrane lining a surface between the outside world and your tissues. It's attached to a basement membrane, which is made of extracellular secreted matrix material. Most of these surfaces are, in fact, not all, but many of them are associated with secretion of mucus. Some of them have cilia, such as the pseudostratified squamous epithelium that lines the airways. Mucus is the mucus that gets secreted in most of these sites, if not all, actually contains IgA class antibodies, so that's added protection, and also non-specific small proteins, peptides, that have antibacterial activity. Now, normally on skin, there is a microbiota, a normal population of bacteria that are generally all gram positive, and they are quite salt tolerant. They can tolerate the higher salt levels that you find on the skin. Typical ones that are found on everyone worldwide are Staphylococcus epidermidis and Propionibacterium acnes. Those are the two main organisms that are found on the skin, and they compete for the nutrients and space on the skin They compete so that it makes it difficult for pathogens to get a foothold. Now, in terms of actual disease process, what we often see are rashes. If the rash is on the outside surface, on the squamous epithelium, stratified squamous epithelium of the outside, it is a exanthem. And if it's on the inside, on the mucosal epithelia, it is a enanthem. So those two terms differentiate between the outside stratified squamous, or the skin epithelium, and the internal mucosal epithelium, the exanthem and the enanthem. Rashes on the skin include or can be seen with measles and German measles or rubella, and also with scarlet fever. There's a redness on the skin. In terms of internal mucosal membrane rashes that can be observed in the throat with measles, you get a characteristic sign of measles, which is Koplik's spots. Measles is called rubeola, and German measles is called rubella. These are two completely different viral diseases or infections. Often associated with skin disease in the skin is these red lesions or rashes, and sometimes they can have fluid-filled spaces. If it's less than a centimeter, it's called a vesicle. If it's larger than a centimeter, it's called a bulla. And these are both fluid-filled space or vacuole, vesicle in the skin. If it's filled with, if it's flat, not filled with any fluid or any accumulation of white blood cells, then it's called a macule. So you can have a macular rash. It's a flat reddened lesion. And if it's filled with pus, then it's called a pustule. It's raised, just like these other ones are raised here. So just fluid is a vesicle, or if it's larger, it's a bulla. If it's filled with pus, it's called a pustule. And if it's flat, because there's no accumulation of any fluid or pus, then it's a macule. So a macular rash is a flat reddened lesion on the skin. Okay, so I'm going to talk about different organisms that can cause skin infections, and the two of the major ones are Staphylococcus and the other one Streptococcus. And please pay attention to the difference, that keep them, they do sound similar, they're spelled similarly. Don't confuse them. It's often done. Don't. Staphylococcal infections and streptococcal infections sometimes overlap in their appearance, so try and pay attention to keeping it separate. In terms of staphylococcal skin infections, the normal microbiota, which doesn't cause any infection, the normally present is Staphylococcus epidermidis, I told you before. There is also there can be Staphylococcus aureus. Some of them, not all, but some are pathogenic. Both of these are gram-positive cocci. The pathogenic ones can produce toxins, including leukocidin, which is able to kill white blood cells, phagocytic white cells. And another type of toxin that some of the Staphylococcus aureus organisms, strains, can produce is exfoliative toxin. So leukocidin and exfoliative toxin are associated with staphylococcal infections in the skin. Here you see Staphylococcus forming a biofilm. I spoke to you about biofilms before. Quite difficult to remove and quite resistant to antibiotic treatment because the film forms on the surface and gets covered over, and so penetration of antibiotic is difficult. Often you get these biofilms forming on the surface of plastic tubing or catheters that are into the patient, so that's the reason why they have to be changed. You can't leave them there forever. You get a biofilm on it and it can be a source, a foci of infection. Well, the kind of things you get with staphylococcal infections include folliculitis, which is an infection of the hair follicles, stye. A stye is found in the eyes. It's a folliculitis of the eye of an eyelash, very common occurring kind of infection. A furuncle is an abscess, pustule. You have an area with pus in it. It forms into an abscess. It's surrounded by inflamed tissue. If it extends deeper into the tissues, then it's called a carbuncle. Okay. Now, staphylococcal skin infections can end up have multiple kinds of progression or different kinds of presentation. In a newborn, you can get impetigo, which is a crusty infection on the skin. It can get into the blood, so you can get toxemia due to staphylococcal infections. Sometimes because of the exfoliative toxin, what you get is this scalded skin syndrome. It looks like a burn and the skin is peeling, and that's what's shown here, red and peeling. Staphylococcal infections can cause toxic shock syndrome, which is a widespread activation of many T lymphocytes, triggering them to produce cytokines, and that induces fever, vomiting, scalded skin syndrome. And this is quite a serious skin inflammation, which has to be treated with antibiotics. It can appear like a sunburn and can also be caused by strep, so that's one of the things that can get people mixed up. So staph can also cause cellulitis, not that uncommon inflammatory infection of the skin, potentially quite serious. Appears as a swollen red area of the skin. It feels, typical inflammation, hot, pain. It's tender, can spread very rapidly and can spread further into the tissues. It's taken quite seriously, cellulitis. So that's staph. Now we'll talk about streptococcal infections. This is completely different. This is a completely different genus, right? Streptococcus. So now we'll talk about streptococcal skin infection. The organism in this genus that causes probably the biggest problems are certain strains of Streptococcus pyogenes. Streptococcus pyogenes, one variant of them are the group A beta hemolytic streptococci, gas organisms. Group A streptococci. That's gas comes from these letters here. So group A beta hemolytic streptococci. This is the fairly quite serious, can cause quite serious infections. They can be alpha, beta, or gamma hemolytic in terms of their effect on red blood cells. I remind you that on a blood agar plate you can get 3 appearances or 3 effects on the red cells. It could be alpha hemolysis, which is a partial hemolysis of the red cells resulting in the hemoglobin turning into a green color. Beta hemolysis, which is complete hemolysis, so there's a clear area underneath the bacteria growing on the plate, or gamma hemolysis. and I refer you back to, which is no hemolysis actually, and I refer you back to lab 6, in which we looked at that. The slides in lab 6, I include a blood agar plate with alpha, beta, and gamma type of hemolysis on it. Now, streptococcal infections in the skin can be localized and are generally localized and non-invasive. They don't invade down further deeper into the tissues, but some can be invasive. And first we'll talk about the non-invasive ones, and then we'll discuss the invasive, even more serious types of infections. Okay, in terms of non-invasive streptococcal skin infections, which are caused by Streptococcus pyogenes, group A Streptococcus. These are localized. Two examples of types of infections that you can see include erysipelas, which is an infection of the dermal layer and shows this kind of red skin rash that you can see, and impetigo. This is a particularly bad case of impetigo. You get these you get these isolated crusty infectious areas, pustules, typically around the mouth, typically in little kids, young kids. They put all kinds of things in their mouths and they get it. So these are non-invasive. The more serious are the invasive kind of gas or group A streptococcal infections in the skin. The variants of Streptococcus pyogenes that can cause this are typically able to produce enzymes that help the organism penetrate and advance through the tissue, and that includes streptokinases or hyaluronidase. Streptokinase is quite good at destroying blood clots, so that helps the organism advance through. As tissue gets injured, there's bleeding and blood clot formation that helps to isolate the infection. But because of the streptokinases, these varieties of Streptococcus pyogenes can work their way through. Hyaluronidase breaks down hyaluronic acid, which is part of the extracellular matrix in tissues. The other thing is that some of these organisms can produce toxins which act as a superantigen. So exotoxin A, for example, can act as a superantigen. And again, I remind you that superantigens are molecules that can widely activate T cells, regardless of the specificity of the T cell receptor on the T cells. That many of them are activated and start producing cytokines, which results in quite a strong reaction and can lead to quite a severe infectious process. These organisms, just like Staphylococcus aureus, some Staphylococcus aureus varieties can cause cellulitis. And the other thing is, and this is quite serious, is necrotizing fasciitis. This is a inflammatory process of the fascia, a connective tissue layer that surrounds tissues like the muscles, and is also necrotizing, so it causes cell death and it causes the infectious process to advance very quickly. So these can be quite serious. Here you see cellulitis. It can be this is not a particularly subtle case, but it can be fairly subtle red rash, and it's not everyone who can recognize that a redness on the limb is cellulitis infection, cellulitis associated with infection. But it can be potentially quite serious. You get swelling of the limb and then a red area on the skin. It'll feel hot and tender. It can spread quite rapidly. Necrotizing fasciitis, on the other hand, the common name for this kind of infection associated with streptococcus is flesh-eating disease or flesh-eating bacteria. That's not a good sign when something is called flesh-eating disease. It destroys tissue very rapidly. And it says here almost as fast as a surgeon can remove it. The point is that if it's diagnosed in a limb, the treatment is to amputate. And they have to do it right away. There's a 40% mortality associated with this kind of infection of necrotizing fasciitis associated with group A streptococcal infections. Gas. Okay, let's move on to another, in this case, gram-negative organism, which is Pseudomonas aeruginosa. These cause what are called pseudomonid infections. Pseudomonas aeruginosa is everywhere around us. It's, on our external environment, on and off, and you can pick it up very easily. It often doesn't cause any problem, but it can sometimes cause infectious disease. It can cause a dermatitis. It can also cause a infection in the outer ear, and is typically often associated with infections in burn patients, people who have burns in the skin. So you can get a post-burn infection with Pseudomonas. One unique feature of this organism is that it will produce a blue-green dye, a blue-green color product. So if you do see a blue-green colored pus, for example, then chances are it is a Pseudomonas infection. Okay. We're on skin. We'll talk about acne. It's a common skin disease process. About 85% of teenagers get affected by it to varying degrees. The production of sebum from the oil glands in the skin is normal, but there's an accumulation of cells and sebum that can block the hair follicles, tiny hair follicles, and that results in acne. The blocked follicles will result in acne. There are three categories of acne. There is comedonal acne. The channels are blocked and can easily be treated with simple topical agents that reduce inflammatory responses. There's inflammatory acne, in which case there is an infection. The blocked follicle starts to grow Propionibacterium acnes, which is a normally found microflora. It's normally found in the microflora of the skin, but you get more growth in this case. And the treatment is to prevent or slow down sebum formation, sometimes antibiotics. This is only with this is much worse, the second kind, than the normal kind. Sometimes light therapy. The third kind, which is the most serious of the three, is nodular cystic acne, which causes scarring and has to be treated. I'm not going to ask you the treatments. They're here. Treatments are here and shown throughout these next slides, but I would not ask you for specific treatments. Okay, so let's we're finished with the most common kind of bacterial infections of the skin. Let's talk about viral infections of the skin. And when you're talking viral infection of the skin, it's really, you're going to talk about human papillomavirus, or HPV. There are many strains of the human papillomavirus. Some are more serious than others because some of them are certainly the underlying cause of carcinoma, epithelial cancers. And we'll talk about that in the next few slides. These are the kind of viruses that cause warts. So papillomaviruses have approximately 130 different strains or types, subtypes that have variants that have been identified. About 30 or more of those are sexually transmitted. The virus infects an area of skin that has some small injury on it and can cause warts at that area, and it can be anywhere on the body surface. Can infect the the hands, the face, anywhere, and including the genital area in both males and females. The areas infected are typically on the skin of the penis, on the vulva or the anus, the lining, internal lining in the vagina, and the cervix or the rectum. All of these can have infected genital warts caused by certain types of papillomavirus. Not all, some of them, quite a few. Well, this is something that's very difficult to avoid. About 50% of sexually active, and I'm talking about non-vaccinated now, about 50% of sexually active males and females will acquire genital human papillomaviral infections. And by the age of 50, when they test, they find, again, in the non-vaccinated population, more than 80% of females will have a genital human papillomavirus or HPV infection. Most infected people, even though they have an infection, will not have any symptoms or any sign of the infection, will not have warts, but will have will have been infected. And these kind of infections are cleared and nothing's seen and it's gone. However, certain strains can cause persistent infections. The virus is there, and certain strains of the 130 different strains are a major risk factor for development of cervical cancer. So this is cervical carcinoma. Carcinoma of the cervix. The cervix, of course, is the part of the uterus that projects into the vagina. So clearly a serious problem. However, that you can reduce or prevent. There's two ways to prevent almost all cases of genital human papillomaviruses, which can lead to cervical carcinoma. One way is by human papillomavirus vaccination. There has been a very effective vaccine developed and has been available for the past 15 or 20 years. Or no genital contact. Now, no genital contact tends to be a difficult thing for many people to follow, and in fact probably ends up meaning that people would not have any children. There have been religious groups in the United States that did not believe in genital contact. In the 1800s there was a group. They're gone. They're not around anymore. They didn't believe in having any sex, which is fine, but and will prevent genital HPV. But for the vast majority of people, vaccination is, perhaps more realistic. And prior to becoming sexually active, reduced risk is associated with having fewer sexual partners. But hey, one's enough. You don't know. And the best for significant reduction of cervical cancer. Okay, this is reduction of, genital infection with the human papillomavirus, these two. And this is for significantly reduced risk of cervical cancer. It doesn't mean that you can't develop a cervical cancer. There are other reasons why you might, but human papillomavirus vaccination is one of the best ways of reducing the risk tremendously. There are 2 of the 130 different types of human papillomavirus that are associated with 70% of cervical carcinoma cases. They are type 16 and type 18. There are 2, at least last time I checked, there are 2 human papillomavirus vaccines on the market. Don't worry about the names, but these are the 2. Both have shown to be, and this is quite dramatic, 100% effective in preventing the infection with these 2 types. Gardasil also has offers additional protection against 2 other types that are associated with about 90% of genital wart cases. So, by taking Gardasil, for example, you are reducing the odds of significantly reducing that 70% of cases associated with cervical cancer that eventually might occur. And also genital warts. 90% of cases of genital warts are caused by these 2. The only side effect in the vaccine is a temporary soreness at the injection site. So, if you happen to not feel hesitant about vaccination, then, think about the risks. One is the benefit would be you will avoid temporary, and like we're talking like a half a day or a day, soreness at the injection site versus developing cervical carcinoma or getting genital warts. Well, I think I've made my point, I hope. Okay. Now we're going to talk about a disease which no longer exists among the human population, and that is smallpox. Smallpox is caused by a virus called variola. There's 2 actually, variola major and variola minor. Smallpox was tremendously feared and caused outbreaks worldwide. It was everywhere, but a vaccine was developed. In fact, vaccination was developed before the ideas or the concepts or the mechanisms of immunology were understood. And that's because Jenner realized that women who milked cows didn't develop smallpox. Cows have a closely related infection with a virus, a closely related virus called vaccinia, which causes cowpox, and these women who were milking cows would get cowpox on their hands and never developed smallpox. So you realize if a person got cowpox, then they were protected against smallpox, and that's actually where the word vaccination is derived from, the name for cowpox, which is the genus name, which is vaccinia. Well, the vaccine is completely protective, and the disease smallpox, this virus is only found in infecting humans, and so with a very proactive and aggressive kind of vigilant vaccination program worldwide, they were able to declare the disease eradicated in 1979. Okay, let's talk now about herpes virus infections in the skin. The first one we'll talk about is human herpes virus 3, HHV3. This is caused by a virus called varicella zoster virus, also called human herpes virus 3, HHV3. The disease that this virus causes is chickenpox or varicella. They both mean the same thing. I know this nomenclature stuff is a little difficult, but you know, the common name in the general public is called chickenpox. It's also called varicella, and the virus has this name, varicella zoster, or more recently they've tried to categorize and make it simpler for the human herpes viruses. It's called human herpes virus 3. It's transmitted by the respiratory route, easily transmitted between people. It causes vesicles on the skin, which are pus-filled, so that, I guess, would be pustules, vesicles that become pustules. It unfortunately does not, once the symptoms disappear, it does not mean that the virus is gone. It can remain latent, not causing any symptoms, not being evident, but remain latent in the dorsal root ganglion, in the nerve cells of the dorsal root ganglion. I remind you that when you look at a cross-section through the spinal cord, the you see the dorsal root and the ventral root. Sensory signals come in from the body into the dorsal root, and motor signals go out through the ventral root to, excitable tissue, muscles or glands, right? So that's outgoing in terms of nerve impulses. This is incoming in terms of nerve impulses. The cell bodies of sensory neurons are found in the dorsal root ganglion, which is an accumulation of nerve cells just outside of the spinal cord. This is all reminding you of things you've learned before. And the virus can remain latent inside these nerve cells in the dorsal root ganglion. So it remains there later and can reemerge at a later date, unfortunately. And it can reemerge and cause a disease process called shingles, also called herpes zoster, which is a latent activation, which is a reactivation of the latent HHV3 infection. So now the virus comes out and goes along the sensory nerve, and will cause lesions in the skin in that area. And it depends on which sensory dorsal root it comes out of. If it's associated with the face, then it'll be, the left side, the right side, and a sort of a strip along the body. Here they're showing that this strip is, well, also this, it's got to be one, not both. It could be here or alternately here on the other side. It can be, as stripes in a striped area on the body, whichever dorsal root ganglion is involved in the release of the viral infectious virions. This will happen, this kind of reactivation can happen if a person is fatigued or immunosuppressed or exposed to a lot of UV sunlight irradiation. Can happen with age, because as you get older you become immunosuppressed. So they're latent in the dorsal root ganglion and they can reemerge. They'll then release infectious virus particles that will move along the peripheral root of the sensory nerve to the skin and cause shingles. Shingles can result in lesions that go away, but the pain, there is severe long-term pain often associated with the infection. And it can be painful in that area for the rest of the person's life. Luckily, however, there is a vaccine available. It happens to be called Shingrix. It's something that's highly recommended. Okay, let's talk about another kind of herpes virus infections. These are the older name but still used, herpes simplex 1 and herpes simplex 2, also called HSV1 and HSV2, or better, more recently called human herpes virus 1, HHV1 and HHV2. These are the viral infections that cause cold sores, sometimes called cold sores or fever blisters. These are vesicles on the lips, and it's missing here on the genitalia. HSV1 can remain latent in the trigeminal nerve ganglia. That's the nerve ganglion that innervates the face near the mouth. Or HSV2 can remain latent in the sacral nerve ganglia, that's innervating the genitalia, or vice versa. It used to be thought that HSV2 were associated only with cold sores of the genitalia and HSV1 with the mouth, but it can be either way. There are some very good topical antiviral ointments containing acyclovir or related, more recent developed antiviral compounds that can, if put on early enough, can certainly, prevent the kind of lesions that you get with a cold sore. But the best is really to get a, no, I'm sorry. I was going to say there was a vaccine. There isn't. Okay, so we've covered HHV1 and HHV2 that causes cold sores, and HHV3, which causes chickenpox, and later on reactivation can cause shingles. Let's cover now, we're going to talk about measles, also known as rubeola. So the measles virus is also called rubeola. It is transmitted very, very easily through the respiratory route. If there's one person infected in a closed-in room, then 90 or 95% of people in that room will get, if you sit in there in that room, like a classroom, for example, with 30 students, and there's not any special ventilation in any way, then you'll have 90 to 95% of people getting infected. However, there is a vaccine that almost everyone receives, except for those who are against vaccination. It causes a macular rash. Remember, macular rash is a flat and red lesion. There's no accumulation of fluid or pus in the lesion. And here you see in this photograph a child with the macular rash. It also causes Koplik spots, which are lesions in the mucosal epithelium of the throat. It can be, as I said, prevented by vaccination, which young children will get. It's the first M in MMR. The MMR vaccine, which is given at quite an early age, I think several times, 2, 4, and 12. I'm not sure about the months. Maybe we'll see it. We've gone through that. The first M stands for measles. It's measles, mumps, rubella. Rubella is German measles, so measles, mumps, rubella, MMR. It's the M in MMR. Unfortunately, measles is serious. And so is chickenpox. No, let's stick to. So measles is serious. It can cause serious infections. In a small number of cases of infections, you get an encephalitis. I mean, people die from this. It's not something that should be ignored, and to not vaccinate is really criminal, irresponsible. It's hard to call it criminal because it's not necessarily, but it's certainly irresponsible and not protecting the child. It can cause either encephalitis or, in very severe case, sometimes you'll get subacute sclerosing panencephalitis, which is quite deadly. Here you see the effect of vaccination against the measles virus. It was first developed in the 60s here at this point. This is time along the horizontal scale, and number of cases along the vertical scale here. So this is time this way and cases going vertically. And you see with vaccination, the vaccine being licensed and given, the number of cases, these are statistics from the United States, the number of cases just absolutely dropped down to hardly any. There have been some more recent outbreaks because anti-vaxxers believe that they know better and that the vaccine is going to needs to be avoided for some fairly creative false reasons. Again, I would say totally irresponsible behavior. This inset here is the same going in more recent years from 94 on, but with a different scale for the number of cases so that you can actually see, because they've dropped so low on this scale that they're putting in a new graph here, and it's really dropped down to very, very few. But there was a serious outbreak. There have been serious outbreaks in the past few years among unvaccinated children. German measles, which is the R for which stands for rubiola, because rubella. Measles is also called rubiola, but German measles is called rubella. It's the R in MMR vaccine. It causes also a macular rash, quite similar in appearance to measles. It can cause also a fever. Can cause severe damage to a fetus. If a pregnant woman gets it, it's really can be terrible damage to the fetus. I believe it's causes abnormal neurological development. Okay, so that completes covering. First, we covered bacterial infections of the skin, and then viral infections of the skin. Another type of infection are fungal infections or fungal disease of the skin, and one of the most common ones is infection with Candida albicans. Infection is called candidiasis. It's a very common yeast infection. We all carry Candida on us and on our internal surfaces. It's typically outcompeted by the normal microflora and bacteria on the skin. But if those bacteria are killed off because of heavy antibiotic use, if a person is being treated with a lot of antibiotics, it is possible that the competing bacteria are all killed off, and then you get an overgrowth with Candida, which is called candidiasis. It can also occur with fatigue. Candidiasis or Candida infection can occur with some immunosuppression or fatigue, etc. It occurs in the skin and also the mucous membranes of the genitourinary tract and in the mouth. In the mouth, it's called thrush, and it can be fairly easily, I believe, treated with topical application of and also let's leave treatment alone. Treatment changes as new treatments get developed and new things are treatment is changing, and I'm not teaching treatment here. I'm teaching the characteristics of different infections and the science behind those organisms. Okay, Here you see, in fact, a thrush in the mouth and throat. This is on the tongue. It's a yellow appearing, heavy infection with Candida albicans, leaves a yellow appearance. Sometimes people who are immunosuppressed and because they're on being treated with drugs for cancer, they get infections with bacteria and they're treated with antibiotics. So between the antibiotics getting rid of all the normal bacterial organisms and the immunosuppression associated with the treatment, they sometimes get serious Candida infections of the gastrointestinal tract. The whole lining of the gastrointestinal tract can be yellow with the organism, the internal surface. Okay, that was fungal infections. I mean, there are other fungal infections of the skin, but we're not going to talk about them now. So the bacterial, viral, and fungal. Now we'll talk about some parasitic diseases of the skin. Everyone can get on them. These small, tiny insects that are called mites. They're really microscopic. They're all over the place, particularly in carpets, but they can be on the skin and cause what's called scabies. This is caused by the mites burrowing into the skin. Pediculosis is our lice. Humans get lice. There are lice in different areas of the body. There are head lice. There are body lice. There are head lice are found in the hair on the head. Body lice. Louse is a single one. Lice is plural. Head lice typically and body lice typically can be detected by finding what are called nits. Nits are these egg cases that the lice, these insects, these small insects, attach to the shaft of a hair. So this is a extremely high-powered view, photomicrograph of hair shaft, and this structure here, I'll outline it darker. This structure here is a nit, typically a lighter color, so it can be identified. It's more difficult to identify against blonde hair, I think. Lice, pediculosis. Okay, I think we're going to stop here. This is the end of Lecture 19, Part 1.